We'd like to welcome everybody out to our annual HCA Program Integrity webinar. And we'd like to remind people that much of the PowerPoint is going to be read verbatim because it's very important that we cover the things that we need to be covered. And we'd also like to mention that this will be recorded and put on the website, and if people were unable to get in, then that will be something that they can just listen to later. And also, we're not going to have questions during the webinar, but any questions that you have about anything that's been said, please feel free to post them on the Healthcare Authority email, or send us via, all of our contact information will be at the end. So we're going to start off. Let's go ahead. We're going to go ahead and talk a little bit about the disclaimer. And basically the disclaimer is that this is not intended to be something that covers every law and every regulation that you need to be able to be in compliance with the Medicaid laws. And so if you have any questions, you should seek a consult with your legal counsel. And the objectives that we're going to cover today of the presentation is we're going to go over a general overview of program integrity and our activities. We're going to give you a summary of some of the audit results that we've had and common issues that we had over the last year. We're going to talk a little bit about the problems and mistakes that we've identified. And then we're going to talk about some new things that are coming up, some things that are changing, and some things where there's a new focus. PPCs, a lot of people noticed that PPCs were a big focus last year, and that's not going away. Those things are changing. And also, we had some CMS recommendations that we're going to talk a little bit about that are have to do with program integrity. And we're going to also talk about the False Claims Act and some of the rule changes that are going on with that. So program integrity is a federally mandated program so that we can protect the integrity of all Apple Health programs. And it prevents and identifies and investigates potential fraud, waste, and abuse. And when we come across something that is fraudulent, like credible allegations of fraud, those are referred to the Medicaid Fraud Control Division or other law enforcement. And we ensure that Apple Health funds are appropriately paid. And we also review MCO encounters as well through program integrity. And program integrity's objective is to identify fraud, waste, and abuse. And we do that through audits, pre and post payment. We also do some clinical reviews, pre and post payment. We might do utilization reviews. We do data analytics and algorithms, and we'll talk a little bit more about that later. And we do investigations of potential fraud, and then we do education and outreach. And so these are the areas that we focus on through program integrity. Then the PI audits overall focus on any provider, service, or MCO. They can be routinely scheduled, or they can be based on complaints or outliers, and they involve a record review and draft report findings with informal dispute process. And then we also have a potential for adjustment to the findings. So like if we have findings and perhaps something wasn't doesn't look like it was correct, then you have an opportunity to dispute that. And then we will put out a final notice, and then we have a formal appeal process if you still disagree with the findings. And the final goal here is to make sure that improper payments are resolved. So inpatient hospital audits are also based on a similar system to all the other audits. They also involve record review. They can be found through referrals, complaints, or outliers through data mining. They involve record review, and you get a preliminary notice with informal dispute process, and you have the opportunity to dispute any of the findings that are found. And if we find that there's something that was not found in the records that actually occurred and justifies the billing in that way, then we will reverse our findings. And if you disagree with our findings after the final notice, you have a formal appeal process. And of course, our goal is still improper payment resolution. So then we also have data analytics and algorithms, and those are a little different because the focus is not on a particular provider, it's on a particular service or a particular provider type or a particular claims problem. And so what we do there is we will identify, those are identified through a similar system. We get referrals, we get complaints, we also find outliers, and occasionally something will happen and we will realize that an edit's been changed or an edit's been turned off, and we will find a edit vulnerability. And in those cases, we just issue an overpayment notice. You still have the opportunity for an informal dispute, and if your informal dispute does not result in something that is successful, then you still have a formal appeal process. But it's something that is literally, we've overpaid this, we know that it was an overpayment, we send out a notice letting you know that it was an overpayment and we're taking the money back, and that's the way it goes. And we also, the goal here is overpayment resolution. Investigations is also an area that's very different. Investigations are focused on provider, service, or MCO. They can be based on referrals or complaints. We can also investigate due to outliers in billing practices. We research into the provider background and billing patterns. We can also go and interview people and do potential on-site visits. And if we find that in an investigation that there's credible allegations of fraud, those will be referred to the Medicaid Fraud Control Unit. And in those cases, sometimes we will do a payment suspension. And so if the Medicaid Fraud Control Unit is taking over a case from us, we may suspend payments to keep those payments from continuing to go out. And then PI referrals. If a audit or clinical review, utilization review, or investigation identifies potential fraud, those are also investigated per the previous slide. And when we find that that there's credible allegations of fraud, we can send those on to other units and other areas. Usually law enforcement, including Medicaid Fraud Control and the Department of Health or other law enforcement agencies. like the OIG. And then the most common program integrity findings this year, once again, are documentation. If there's a missing order for something, or if documentation does not support the charges that have been made, then we take those back. Insufficient documentation. We've also found that a really common finding was upcoding, and that is related to DRGs, also procedure code upcoding, and level of service upcoding, and level of care inpatient versus outpatient upcoding is something that we find very common. And then non-covered services, such as over the limit or unbundling, are common findings that we have had this year. And then the last one is services not rendered. Now we're going to talk about a program that we've had particular focus on for quite some time. It's provider preventable conditions. The Affordable Care Act of 2010 prohibited payments to healthcare providers for Medicaid services rendered as a result of certain healthcare acquired illnesses. And one of the things about provider preventable conditions is it's been through several different iterations. And many of you remember that there was a big focus several years ago on hospital acquired conditions. And then there was a big focus on never events. And there were even some television ER shows which talked about never events. And I remember going, hey, I know what that is. So provider preventable conditions have gone through a lot of different iterations. And currently, provider preventable conditions has two different flavors. There's hospital acquired conditions and other provider preventable conditions. The rules around provider preventable conditions are in WAC 182-502-0022. They apply to fee-for-service and managed care Medicaid clients. They include inpatient hospitals, but they also include all healthcare professionals who bill healthcare authority for care rendered to Medicaid clients. A lot of people don't realize that because of the history of provider preventable conditions being so focused on hospital acquired conditions. And so, but now, one of the types of provider preventable conditions can be applied to any Medicaid clients and any healthcare professionals, regardless of whether you're a hospital or not. The details of provider reporting requirements are also contained in this WAC. Go ahead. And basically, the focus of healthcare acquired conditions is events that can occur in any healthcare setting, inpatient or outpatient. The CMS website gives us resources and general information, and the WAC gives us the specifics. The other provider preventable conditions were the second type. They only occur in an inpatient setting. The National Quality Forum identifies mandatory OPPCs under 42 CFR 447.26, but additional OPPCs are also state defined and are listed in our WAC. When you have a provider preventable condition, you're required to report those within 45 calendar days of the confirmed event. And what we have determined that to be is when you're made aware that it was a provider preventable condition, not when the event occurred. Facilities or providers must report on Healthcare Authority Form 12200. We recently revised that so that it would be routed to Program Integrity. And it's located in Healthcare Authority's Provider Billing Guide. Failure to report will result in loss or denial of payment. Cases that are selected for PPC are generally found through data mining. The federal government releases every year lists of diagnosis codes and procedure codes that indicate that something may be a PPC. And we look through the Provider One payment system and review all of the diagnosis codes that are used and identify those that meet the PPC rules. We also keep track of all the ones that have been reported to us so that we aren't taking back more money on something that has already been identified by the providers. The penalty, of course, for non-reporting is that we will recoup the entire payment. When we're doing a PPC review, we will usually request medical records associated with the billing. All requested records must be sent via HIPAA guidelines. We prefer to receive those via SFTP site. And if an event is identified, payment adjustments will be made, and this follows the same category as other audits. And so you still have the informal dispute process and the formal dispute process that I spoke of earlier. We can be really clear in exactly what it was that was not reported or what it was that we had as a finding. So I'm going to turn the time over to Greg. He's an attorney who works for Healthcare Authority, and he's going to speak a little bit about some of the other things that we're going to discuss in today's webinar.
Thank you, Scott. So in the summer of 2018, CMS came in and did a focused review of the Healthcare Authority's Program Integrity, and came out with some recommendations from that review. These were in their January report of 2019 that can be found on the CMS website. And I'm going to talk about some of these recommendations now. The legislature this last year has directed the Healthcare Authority to implement these recommendations. So that's one of the reasons why we wanted to point them out and read them to you now. First recommendation was to organize the program integrity activities into a centralized unit under common protocol, and that was to address provider enrollment, fraud and abuse detection, investigations, and law enforcement referrals. Another recommendation was to ensure HCA and managed care organizations, or MCOs, are allocating sufficient resources for the prevention, detection, investigation, and referral of suspected provider fraud. Another recommendation was to align and strengthen the program integrity policies and procedures along with the managed care organization contract language to ensure that there's no contractual impediments to audits of the MCOs or the encounter data or collaborative audits with the MCOs, so that all impediments would be removed. All program integrity functions are being adequately addressed by the managed care organizations, and that mandatory referrals are made of any potential fraud, waste, or abuse. The managed care organization's special investigation unit staff should receive sufficient program integrity training in identifying, investigating, referring, and reporting on providers with suspected fraudulent billing practices. And finally, training to be accomplished in conjunction with the Medicaid Fraud Control Division to enhance the case referrals. Next slide, please. Another recommendation was for HCA to enhance its system for tracking managed care organization investigation referrals by enhancing the Washington Fraud Referral Form, to clarify proper use of the Washington Fraud Referral Form for reporting purposes for MCOs, and to ensure referrals always conform to the CMS referral standards. The Healthcare Authority is to expand random sampling of MCO provider enrollment files to verify that all the appropriate documentation is present, and for the Healthcare Authority to enhance MCOs and Medicaid Fraud Control Division interactions. This will be done by implementing collaborative meetings, training for MCO staff on identifying suspected fraud and doing referrals, and to obtain Medicaid Fraud Control Division feedback on the quantity and quality of MCO referrals. HCA is to enhance the collection and analysis of encounter data reported by the managed care organizations. They should conduct proactive data mining and routine audits to identify fraud, waste, and abuse by managed care organization providers, and ensure MCOs submit accurate and timely reports on all identified overpayments and recoveries, specifying whether overpayments are due to fraud, waste, or abuse. To make sure that processes are in place to ensure integrity of the data being used for rate setting. Additionally, Healthcare Authority is to enhance and refine payment suspension policies and procedures to identify credible allegations of fraud and suspend payment unless a good cause exemption applies. And CMS clarified that this is not to be routinely granted, so only if it meets the specified standards. And then Healthcare Authority is to ensure all federal database exclusion checks are performed for all subcontractors at enrollment, re-enrollment, and on a monthly basis. So now I would talk a little bit about the education requirements related to the False Claims Act, which is sourced out of the Deficit Reduction Act of 2005, Section 6032 requirements. First, let's talk about affected entities are those who receive or pay at least $5 million in Medicaid funds annually, and that's based on the federal fiscal year. And they must inform their employees and contractors in writing about the Federal False Claims Act and related civil or criminal state laws related to the Medicaid fraud. It's very important because the statute makes clear that Medicaid payments may be suspended or forfeited for noncompliance. Next slide. So what is a government, I think we went 2 slides there. Affected entities, per CMS, an entity pretty much includes anything, including individual providers, any type of organizational unit, corporations, partnerships, or other business arrangements, including a Medicaid managed care organization, and irrespective of form of business structure by which it exists, and whether it is for profit or not for profit. In addition, it can be a government agency. So the governmental entity issue, it's worth pointing out that a governmental component providing Medicaid healthcare items or services for which Medicaid payments are made can qualify, which would include the state mental health facility or a school district providing school-based health services. On the other hand, the governmental agency merely administering the Medicaid program is not an entity, which would be such things as managing claims processing or just determining eligibility. Whereas the Healthcare Authority and the Department of Social and Health Services are not entities for purposes of the False Claims Act. These federal requirements establish a liability for any person who knowingly presents or causes to be presented a false or fraudulent claim to the United States government for payment. And then you can see on our slide what knowingly means according to the statute. Again, the False Claims Act requires affected entities to educate their employees and contractors, agents regarding policies and procedures and employee handbooks. It also requires whistleblower protection for persons who report false claims. Next slide. We're going to talk about the payment threshold and that criteria. The $5 million annual threshold includes payments received either directly from the state Medicaid program for programs and services approved under the state plan for Title 19 or under any waiver or demonstration. Payment a managed care organization receives under a state plan, waiver, or demonstration are not aggregated with the payments the managed care makes to its providers. So it's either they receive it or they're paying it out at $5 million. There are exclusions to this requirement, which would be include payments an organization receives through its contract with the Medicaid contracted MCO. So the managed care organization providers, the payments they receive directly from the managed care organization would not count towards that $5 million threshold. So affected entities must establish and distribute written policies and procedures related to the federal and Washington State False Claims Acts. Have policies regarding the handling and protection of whistleblowers, and policies and procedures for detecting and preventing fraud, waste, and abuse. Policies and procedures must be included in an existing employee handbook or policy manual, but if an entity does not have an employee handbook, it is not required to create one. But policies must be disseminated to and adopted by an entity's contractors and agents. Again, the timeline for determining the $5 million threshold is based upon the federal fiscal year, which is October 1st through September 30th. And notices with the attestations are mailed generally to the entities that are identified as qualifying, generally around sent out around March 31st for the previous fiscal year, and must be submitted within 60 days of receipt to the address identified on the slide. So the state plan and the Washington Administrative Code concerning compliance with the False Claims Act have recently been updated for enforcement of the federal requirements. The rules are located, as you can see, in WAC 182.502.0016 and 182.502.0017. So after January 1st of 2020, non-compliance with the HCA or DSHS request for an attestation and potentially providing copies of the policies and procedures may result in a payment suspension or forfeiture of Medicaid payments to a qualifying entity that is non-compliant. So if the agency determines there is a non-compliant entity based on not receiving documentation by the deadline, a process may be established where that the agency will give a phone call to the provider, maybe even a site visit, and then a warning notice, and then a final notice identifying the effective date for sanction or non-compliance. So at this point, we've come to the end of our presentation. We have some resource links for you to note there that you may want to check out. And there's another slide. Okay. And
this is our contact information. Once again, if you have any questions, if anybody has any questions, they can report those to the Program Integrity inbox, which is listed here. They can also fax us or phone us with anything that they have as problems. And if you have any reports that you would like to make of potential fraud, waste, and abuse, our hot tips address is also listed here. And so feel free to contact us. Thank you.
Thank you for your time today.